Hi, everybody. Happy Tuesday. Welcome to our CCRN webinar today. So excited to see you guys. I feel like we were just here, but it was like a month ago-ish, maybe 3 weeks or so that we were here last. But it just feels like it was just last week. I'm excited to be back with you today. Today, I've decided we are going to have a little bit more of a focused um, webinar today. We're going to talk about CV pharmacology instead of just going through random practice questions. We'll continue to do that in the future, but I just thought this would be kind of a fun change of pace. It'll still be interactive and basically my goal is to go through all of our continuous infusions that we use in shock states for inotropic support, inopressor support, vasopressors, and make sure we feel really confident about differentiating the ways that those medications work. That is something that I think is really helpful as you go in to take your CCRN, but also even more so, super helpful for your practice. And it's something that in the course, if you guys are using the CCRN Archer Review course and you're going through the videos, I spent a little bit of time on this, but I wish I had spent a little bit more. And so I'm kind of using this webinar as a way to do that. And I've done this webinar in the past, like 6 or 7 months ago, and I think it was really helpful. So I wanted to, since it's been a while, we've got a whole new crop of people taking the CCRN now. Wanted to revisit it and offer this again because it is just so important. And I know for me, I worked in a cardiac specific ICU for 4 to 5 years before now working in a more general ICU. So we played around with these medications all the time, especially in that cardiac unit. But I still do that here in a general unit. So I just think it'll be a good use of time. So I'm excited. I'm going to spend a couple minutes talking about the CCRN just in case there's some first timers here. If y'all, while I do that, will throw in the chat where you're from, where you're at in your CCRN studying journey. Do you have a test date scheduled? How many years have you been an ICU nurse? You can really just tell me anything about yourself so that I can learn who's here. It's always fun to get to know you guys, and especially if you come back for a few of these, I typically will start to recognize your name and all that fun stuff. So I'll talk about the CCRN really quick while we do that. So here are some quick facts about the CCRN. So the CCRN is our critical care registered nurse certification. So if you're watching on YouTube or NCLEX, or I'm sorry, YouTube or Facebook, and you're used to seeing NCLEX webinars, this is a CCRN webinar. So this is for current ICU nurses that are looking to become certified in their specialty of being in the ICU. And it's something that you can take this certification exam after 1,750 hours of critical care experience. If you're working full time, you can do that in just under a year, typically. Maybe even less than that if you pick up some extra shifts. When you sit for the exam, you'll take 150 total questions. 125 of them will be counted, and you need 83 out of those 125 to pass, 83 to be correct. That's about a 67% score. This I need to update. I took this slide from the last time that I did this webinar. So last year's talking about 2023. I want to say 2024 had a lower pass rate, if I remember correctly, somewhere in the 70s. So we're hoping to see that increase this year. Reasons to become certified. Hopefully your hospital's paying you more if you're certified. That is the dream, right? And a lot of hospitals do. I know mine, I get a little shift differential for being certified, which is absolutely how it should be. If you're interested in going back to school, specifically CRNA school, this will be required. A lot of CRNA programs now are requiring you to put your score. So what did you actually score on the CCRN? Not just that you passed. That's kind of a new development in the last year or two, which is really changing how nurses are studying for this exam, because they want to not only pass and get that 67%, they're looking to make a score out of 100 out of 125, that sort of range. So it's kind of changing the study patterns a little bit. But yeah, going back to school, and then just overall confidence at the bedside. I say that every single week or every single time we do one of these, because that was the biggest impact for me. When I prepared for my CCRN, it bridged the gap on so many different things that I saw every day in practice, but didn't fully understand. And I think I thought I did. I think I thought I had a really good grasp on a lot of things. And then I prepared for my CCRN and I just thought, oh my gosh, I actually did not know how this worked. And I maybe knew enough to get by and make sense of things, but it really helped give me a fuller picture of why we use certain medications for our patients, why we use certain interventions, what makes one intervention better than another. Just again, bridging the gap on a lot of different concepts. If you are here, hopefully you're already using Archer Review for your CCRN prep, but if not, what we offer is a 1,000 plus question Q bank and then 13 plus hours of on-demand video lectures, as well as these monthly free webinars to go through questions together. All content and questions tied closely to the AACN test plan, which if you know, you know, there's a new test plan coming out in November. So we're going to be making some slight changes to our Q bank specifically. The content side is pretty similar, the test plan percentages. So how many questions you can expect to see from the cardiovascular section versus the respiratory section. Those are the things on the test plan that are changing the most significantly. So definitely take a look at that new test plan. It's available for anybody to go find. It's a PDF on the AACN website. And that is where you can see exactly what that new test question breakdown is. They are adding a little bit of content areas, a little bit more content on burns, for example. But content-wise, it's pretty similar. It's just how many questions you can expect to see in each area. Where can I access on-demand video lectures? That's at archerreview.com. If you go to the CCRN section and you sign up for the CCRN product, it comes with the on-demand lectures and the Q bank all in one. It's a very simple product offering in that way. Okay, we've got Bailey here, who's been a SICU nurse for 1.5 years, taking your CCRN on November 7th, right before that test plan rollout. Way to go. That's the way to do it. I think that test plan, the new test plan is live for testing, any test date after November 12th, I want to say. So you're getting in there right before that change. That's really good. Good luck to you. You've got exactly a month. You're going to be great. That's plenty of time. Okay, let's go ahead and get started. We're actually going to start with just a little bit of lecture material to kind of prime us for the more interactive portion at the end. This is just going to serve as a review of how we, some of the anatomy and physiology behind the systems that medications, our cardiac medications, work on. So let's start with our adrenergic receptors and what they do. These we talk about all the time. A lot of our medications impact these receptors, act on these receptors. And these are receptors that are acted on by our normal body functions as well. So our medications that we use just simulate impacts that can occur naturally. So this is all what nervous system is usually in charge when we're activating our adrenergic receptors? We have two kind of phases of the nervous system, parasympathetic and sympathetic. Which nervous system is in charge when we are activating adrenergic receptors? What do we think? The sympathetic nervous system, right? Our stress, our fight or flight. When we are in fight or flight response, our sympathetic nervous system kicks in to get blood to our vital organs so that we can run from a bear, we can fight an intruder, we can do what we need to do in that fight or flight response. Now, when our patient is laying in an ICU bed and they are maybe intubated and sedated, we will sometimes give them medications to simulate this response or really stimulate this response, make it happen for them. And what we're hoping to do is cause a variety of reactions that increase that blood flow to our primary organs. And when we give certain medications or our body is in that sympathetic nervous system response, that fight or flight, we're going to act on these adrenergic receptors. First of all, over here, we have alpha adrenergic receptors. And the main one we care about is A1. There's technically A2 as well. But the main one we care about is A1. When we stimulate our A1 receptors, we are going to cause a change in our blood vessels. So this is going to impact our blood vessels. And what it's going to do to those blood vessels is cause vasoconstriction. So we're going to clamp down all the hoses in our body. And that is going to do what to blood pressure? We know this. Someone tell me. What's going to happen to blood pressure when we cause vasoconstriction? Yeah, it's going to increase it, right? We've got a tighter hose. We're going to increase our blood pressure. Perfect. And that's really good. That's going to help us get blood where we want it to go, to our vital organs. So when we stimulate alpha 1, we're causing vasoconstriction. So that's our first set of adrenergic receptors. Then we have our beta adrenergic receptors. Now, beta 1 and beta 2, we care about both of them. Beta 1 is mostly found in the heart. Beta 2 receptors are mostly found in the lungs. The way that I remember that is we have one heart and we have two lungs. So beta 1 is for the heart, beta 2 is for the lungs. Now, when we stimulate our beta 1 receptors, we're really activating the CAMP system, which we'll talk about in the next slide. But we're getting to that CAMP system by activating these beta 1 receptors. So we're going to see two main responses from stimulating beta 1. We are going to increase heart rate, which we refer to as chronotropy, meaning we're increasing that time, beats per minute. We are also going to increase contractility. So how hard is the heart squeezing? Both of these are going to increase what? When we increase heart rate and we increase contractility, what hemodynamic value is going to increase? Perfect. Yeah, cardiac output, right? So now instead of just focusing on blood pressure, when we increase cardiac output, we typically see an increase in blood pressure as well. But the main specific hemodynamic value we care about with beta 1 is our blood pressure. Or I'm sorry, is our cardiac output. Thank you. Perfect. So yes, beta 1 is all about cardiac output, and we're doing it two ways. We're doing it heart rate and contractility. So we're affecting all the parts of the cardiac output equation. Cardiac output equals heart rate times stroke volume. So we're going to increase that heart rate and we're increasing stroke volume by increasing contractility. Perfect. Beta 1, all about the heart. Now, beta 2, like I said, mostly found in the lungs. When our fight or flight response is stimulated and we're stimulating all these adrenergic receptors, we are going to I know you can't see chat participation. That is on purpose. It's just so that you can think independently and aren't distracted by the chat. So I can see all the answers, but y'all only see what you put in. Um, so beta 2, yes, mostly found in the lungs. When we're running from that bear, we also need to breathe more. We need to get more air into the lungs, get some more oxygen transport going on. So it's going to cause bronchodilation. All of this makes sense, right? Some theoretical sense. The other thing that beta 2 activation is going to do is cause vasodilation of peripheral smooth vessels. So we're going to have a little bit of a different effect here than the vasoconstriction caused by the alpha receptors. What does that do for the heart? Does this vasodilation help or hurt the heart? If we want our heart to pump more blood out, increase that cardiac output, do we like this vasodilation or do we not like it? I don't think I really asked that in a great way, but a lot of times you guys are totally able to somehow know exactly what I'm saying. We're helping the heart out, right? We are decreasing afterload. Absolutely. Good job. Yeah, this is decreasing afterload. So this can even help increase our cardiac output. Now, the problem is if our blood pressure is really low, sometimes we can't handle that beta 2 activation. And we'll get there when we talk about some medications that cause that and how we have to be kind of careful with what medications we choose due to the fact that some patients their SVR is already too low. Maybe they're in a shock state and they can't handle that vasodilation. And we might have to pair meds together to get the desired effect. Okay, let's talk about the CAMP system. I briefly mentioned this when those beta adrenergic receptors are stimulated. What's really kicking off is this CAMP system within the heart, which is again, stimulated by beta receptors, but there's also some medications that can kind of sneak in without causing beta stimulation. They can cause the CAMP system to occur. And basically what's happening is we're increasing the amount of calcium that is available in the cardiac cells. Calcium is really, really good for contractility. So we're going to increase contractility by increasing that available calcium sitting on the cell membrane, the cardiac cell membrane. And like I said, some medications, does anybody know, we're going to get there, but does anybody know what medication can kind of take a backwards way to get into the CAMP system? It's not It's not impacting beta receptors, but it's still going to cause this calcium increase in the cells. Anybody know? If not, we'll get there in the next couple slides. All right, I'm gonna keep it for oh, what do you call that? Anticipation. We'll get there in a second. So the CAMP system is going to do a couple things to help that heart out. It's going to cause vasodilation. It's going to lower our systemic vascular resistance. It's also going to lower our pulmonary vascular resistance. The medication I'm thinking of really does a good job at lowering that pulmonary vascular resistance. If we lower or we cause vasodilation in the pulmonary artery, what side of the heart can we really help? What side of the heart can we really help if we lower our pulmonary vascular resistance? It is actually the right side of the heart, because the right side of the heart is pumping blood into the pulmonary artery. If we lower that vascular resistance in the pulmonary artery, we vasodilate that pulmonary artery, we're lowering the afterload for the right side. So for right-sided heart failure, we really like these medications that impact the CAMP system. Perfect. Good job. Okay, so that's kind of a brief overview of beta and alpha adrenergic receptors, a little bit about the CAMP system, which we'll talk about more as we get into medications. Let's now go through, this is going to be a little bit more interactive. We've got this chart here with the main medications. When I think about continuous infusions in the ICU, these are, how many do I have here? 7. These are the top 7 that I really think about when I think about the ones we give the most frequently. There's a few I didn't include. Another one that when we're throwing the kitchen sink at a patient, we can give things like methylene blue that have kind of an interesting mechanism of action, but these are our most common ones. So what I want to do is take them all, each one by one, and have you tell me what receptors do these medications work on. And we just walked through what the receptors' actions are, so that can lead us to getting to that main action of the medication. But let's take it one at a time. So phenylephrine. Phenylephrine, what receptor do we know? What receptor or receptors does phenylephrine act on? Way to go, Bailey. That was fast. Good job, Ariel. You should be automatically muted, Kai. Yeah, I'm not hearing anyone else, so I think we're doing good there. Okay, perfect. Yeah, it is all alpha. It is all alpha. So the way I describe these, you'll kind of see it as the chart plays out. Because some medications work on multiple receptors, I like to kind of use a scale of it's either working all on one, and then we have 4 alphas here because phenylephrine is pure alpha. It is pure alpha. Whereas other ones, again, are a mix, but we can see kind of the different ones that they act on. So if we are talking about pure alpha, what's our main action of phenylephrine? Yeah, vasoconstriction, right? And we mean massive, massive vasoconstriction. So this is usually not a first-line pressor because a lot of patients' hearts can't handle phenylephrine very well because it's such huge vasoconstriction. It's really going to increase our afterload. This is something we add if we've tried multiple vasopressors, the patient's already on multiple vasopressors, and we need more. That SVR is still low. We need more vasoconstriction. We can add phenylephrine. Phenylephrine is also given in pushes, really, really small pushes, to just help boost some blood pressure. Excuse me. Boost blood pressure, sometimes during sedation, that sort of thing. If you've ever gotten a patient from the OR and they're still on propofol and the anesthesiologist is coming in and they're just kind of doing little microboluses of phenylephrine, that's a time that I've seen it for sure. Okay, let's talk about norepinephrine. Oh my goodness, I just broke the rule. Maybe we didn't see it, so I'm gonna still ask, what receptors does norepinephrine act on? And you might have seen it, but it acts on one more than another. And that's kind of where my having 4 of each. Yeah, perfect. I always do that at least once when I do these like revealing slides where I like reveal things one at a time. I always like click it too soon, at least one time. So hopefully that's the only time I do it. Okay, perfect. Yeah, alpha and a little bit of beta. So what does that mean? What type of reaction can we expect when we give norepinephrine? We're going to see a lot of vasoconstriction, but now we've got just a little bit of contractility and inotropy, right? Which is a little bit more, it makes it a better agent for the majority of patients than phenylephrine because now we're increasing afterload, sure, with that alpha stimulation, but we're giving a little bit of contractility to help the heart overcome that a little bit. There is one condition. What condition do we give norepinephrine in a lot? It's a first line presser for, yeah, way to go, everyone. Sepsis, right? Sepsis, where we have massive vasodilation occurring. Um, Septic shock, yep. Massive vasodilation. Our SVR is really low. Norepinephrine is a really good drug to help increase that SVR and get our blood pressure higher and give that heart a little bit of help in that stressed state. Perfect. I almost clicked it again and I'm not going to. Epinephrine. What do we think about epinephrine? This one's a little bit it's a little bit nuanced. Yep, we give epinephrine in codes for sure. Yeah, alpha, but mostly beta. And the only caveat that I will have for that, good job, everyone, um, is that with epinephrine dosing, and there's one other medication that we see this with epinephrine dosing, the way it is metabolized in the body and the receptors that therefore acts on can change just slightly. So, as we increase the dose of epinephrine, it becomes more like alpha than it does beta. At lower doses, under about zero point 0.2 mics per kg per minute, if you use that scale in your hospital, I know there's a couple out there. Um, Under that zero point 0.2 mics per kg per minute, we see this being mostly beta. And so it's giving us more inotropy and contractility. As we increase that dose, it really becomes a lot like norepinephrine and is a little bit more alpha. That's still being studied. And we're still getting I think we're still getting more finalized information on exactly where that line is for when that switch happens, and it's probably different patient to patient, but just something to keep in mind. So, main effect, a lot of inotropy, little bit of vasoconstriction. This makes it a good second to third line presser, depending on what your patient is experiencing. I don't love even using the term first, second, third line presser because I think we have to really pay attention to, well, why is this patient needing a presser? Are they in cardiac shock, cardiogenic shock, or are they in septic shock? That really tells us, do they need more vasoconstriction because they're in a vasodilation form of shock? Or do they need more cardiac output assistance because they're in some sort of acute heart failure, something's going on with their inotropy, their contractility. We should really be looking at it patient to patient to determine which medication is going to work best for them. Okay, vasopressin. We did not, full disclosure, we did not talk about the receptors for vasopressin. So this one's kind of a for fun one. Can anyone tell me what receptors vasopressin acts on? Or you can tell me the other name for vasopressin that also kind of is all the same thing. Good job. If you've answered, you're right. So vasopressin is going to act on V1 and V2. So good job. This is going to cause a couple different things. The other name for vasopressin that we can use is antidiuretic hormone, right? When we're talking about antidiuretic hormone, yeah, perfect. What system in the body is being activated with antidiuretic hormone that helps control our blood pressure moment to moment. Our kidneys are doing it all the time. Yep, the renal system, yeah, the RAS system, the renin angiotensin aldosterone system. So vasopressin is going to do a couple things for us. If we're activating that RAS system, it's going to cause some vasoconstriction to increase blood pressure, and it's also going to cause some fluid retention to increase blood pressure. We know if we've got more volume in the tank, we've got a higher blood pressure. So vasopressin is going to work in a couple different ways to accomplish that. And it's a good reason why when we have that septic shock patient, we're on norepinephrine, we've given plenty of fluid already. That's probably why we've started norepinephrine. We've tried fluid, it didn't work. We still need some blood pressure support. We start norepi, we're still not there. We're likely adding vasopressin because it's going to work slightly different than the norepinephrine. And it's going to help that fluid that we've already given go a little bit further theoretically. So vasopressin is a really good second line in septic shock, typically that and hypovolemic shock. Okay, awesome. Let's move on to dobutamine. What receptors does dobutamine act on? Little hint, we're getting into more of an inotropic world. A lot of people call epinephrine a inopressor. Um, these next three are more pure inotropes. Yeah, perfect. Beta 1 mostly, and then just a little bit of beta 2, meaning we're getting a little bit of that vasodilation that can occur just to help that afterload for the heart to make the beta 1 effect go even further. Vasopressin is different than vasopressor. Well, I'm sure I might be missing a brand name, but we call phenylephrine, we call norepinephrine, we call them all vasopressors. Um, but vasopressin's brand name might be vasopressor, and I don't want to mislead you. So I use vasopressor as a very broad term, and vasopressin would just be a type. Um, so yes, dobutamine, all beta. We're causing contractility, we're causing increased chronotropy, and we're vasodilating to reduce afterload. Absolutely. So that leads us to those main actions. Now, if we have a patient, this I kind of mentioned before, let's say we've got a mixed shock patient, meaning they're handling multiple states of shock at once. They have septic shock mixed with a cardiogenic shock from an MI. This would be a patient that we would need to maybe help they hopefully have an assist device if it's caused from an MI, honestly, but whatever the case is, we need to help their inotropy. So we're going to start something like a dobutamine. But if it's mixed with that septic shock, we've got a lot of vasodilation happening already. So we might start to have a patient on dobutamine and also throw in a little bit of norepinephrine to help counteract some of those vasodilation effects. Okay, dopamine. Again, kind of a very different medication. What receptors do we see dopamine act on? Thanks, Clara. This one is kind of a trick question because dopamine is very funny. Okay, let's go ahead and look at it. So dopamine is yeah, so it's very dose dependent, right? Depends on what dose we're on. That really guides its action. So I kind of have this spelled out with some ellipses here. At low doses, so we're talking like 1 to 3 mics per kg per minute, we are going to act on dopamine receptors. These are found in renal arteries, mesenteric arteries, cerebral beds, and we're going to cause some vasodilation in those arteries. So we will do low dose dopamine for like renal failure patients that we're trying to increase some blood flow to those kidneys. We are going to vasodilate that renal artery and get some more blood flow there. So that's all our dopamine receptors that are causing that, D1 receptors. Now, as we go to what we call a medium dose dopamine, that would be 3 mics per kg per minute to around 10 mics per kg per minute. it's going to act like an inotrope. So therefore, it's going to act on our beta 1 receptors and cause our CAMP system to kick off, increase the calcium in the heart, increase inotropy, increase chronotropy, act very similar to a dobutamine in that medium dose. Now, in a high dose, so over 10 mics per kg per minute, and we typically max out around 20 mics per kg per minute, we are going to stimulate the alpha 1 receptors, and dopamine will become more similar to a norepinephrine or a phenylephrine, where we are causing increased vasoconstriction, increased SVR, increased blood pressure. And this can actually cause some decreasing perfusion to the gut and kidneys at that dose, because we know that in our fight or flight response, when we're stimulating those alpha receptors, we prioritize blood flow to the brain, the lungs, and the heart, and the gut gets neglected. So at low doses, we can increase perfusion to the mesenteric and the renal arteries. And at high doses, it's going to do the exact opposite. So the way that dopamine is metabolized in our body at these different doses really, really varies. So that's a little bit spelled out here. But yeah, dopamine's a very interesting drug for that reason. And because of that, when you get an order for dopamine, I've had this happen before where somebody put in an order for dopamine and they weren't really clear about what the reason that patient was on it. I didn't think really the patient needed to be on it. But I don't, I'm not trying to make those decisions, but I was trying to make sense of what we were doing. And the provider didn't put in, they just put in the standard dopamine range, which is 1 to 20 mics per kg per minute. And it's a titratable order. And the titration protocols were for I think it was a heart rate, which I also didn't totally understand. But it turned out that the reason that we were on it was for renal protection, even though the patient was making fine urine. That's why I was confused. And so I'm titrating this, and I end up calling the doctor, and I'm like, I'm kind of confused. And she goes, oh, I didn't want you to go above a 3 on this medication, 3 mics per kg. And I was like, well, that wasn't in the order. Not that I'm just somebody that's going to like blindly follow orders, but this would be dangerous. Like if I hadn't have called you with this concern, somebody could have been following this titration protocol and gone all the way up to 20, causing massive vasoconstriction to the kidneys instead of doing the low dose renal dosing, what we call it. So when we get dopamine orders, we just want to feel really secure about what is our goal here. Are we trying to cause renal perfusion, inotropy, or vasoconstriction? Because that is going to determine how we titrate this medication. And hopefully that's really clear wherever you're working, because that was not a fun experience for me. Okay, let's talk about Milrinone. Milrinone is one of my favorite medications. What receptors is this acting on? This is a little bit more of a difficult one. I'll take a couple different answers for it. Milrinone is another inotrope, but it's not going to act on beta, but it's going to do... Yay! That makes me feel good, Ariel. Thank you. Okay, so this does do with calcium, but it's not a calcium channel blocker. It is a phosphodiesterase 3 inhibitor, so a PDE3 inhibitor. And you're probably like, okay, well, we didn't talk about that. And you are right. Let's talk back about that CAMP system. So the CAMP system's normally kicked off because we've stimulated some beta receptors and we want that inotropy and contractility. So we kick off the CAMP system that's going to increase the amount of calcium that's in the cells. And this is where calcium channel blocker is really not a bad thing to say, because what we are inhibiting is phosphodiesterase 3. PDE3, I'm going to start saying the abbreviation. The whole role of that is to keep things level. So you know how in the body, everything's working on feedback loops, and there's usually a check and balance system. So for everything that we turn on in the body, there's something there to turn it off when things get a little out of hand so that it doesn't get out of hand. So phosphodiesterase 3, PDE3, is sitting in that cardiac cell membrane, gauging those calcium levels. And if it gets to be too much from the CAMP system, PDE3 is going to go in there and settle those calcium levels down. So milrinone is going to be acting within that CAMP system, but not by stimulating beta receptors. It's going to act by inhibiting PDE3 so that when we get more calcium into that cardiac membrane, we don't have something to shut that off. So basically, we're just allowing the CAMP system to work a little bit better, keep the calcium availability high within those cardiac cells. So our effects are very similar to our other inotropes. With inotropy, we're going to also cause vasodilation this way because the CAMP system is going to stimulate that as well. And it's going to do that vasodilation systemically and pulmonary wise. And that's why I personally have seen milrinone used a lot for right-sided heart failure, which we kind of touched on before. It's going to cause that pulmonary artery vasodilation, which is going to reduce the workload on the right side of the heart. So when I've had pulmonary hypertension patients, milrinone's a really good choice. And somebody just asked, why would milrinone be selected versus dobutamine? Is one safer? This is a question I've been asking providers all over the country when I travel nurse, because I felt like providers just had preferences and I didn't totally understand why we were choosing one versus the other, because dobutamine and milrinone are very, very similar. What I will say is I have seen milrinone more for that right-sided heart failure. So if we have a PA cath in place and we've got evidence for increased pulmonary artery pressure, milrinone might be a better choice, whereas dobutamine is going to also cause vasodilation, but it's more systemic than it is pulmonary. So that is when I've seen that differentiation, and really kind of be able to wrap my head around it a little bit better than sometimes some providers just prefer one drug over the other. So hopefully that helps. That's when I've seen some good differentiation. Okay, there's our full chart. You guys did awesome. I hope this helped clarify. I really love to focus on why we give certain medications. When I get that patient in, if we have a PA catheter, awesome. We've got so much more information to help make decisions on what medication is going to be best for them or what combination of medications is going to be best for them. But I like to really be thoughtful with, obviously working as a team with the providers and pharmacy on what does this exact patient need based on how they're presenting, instead of, well, our first line pressor is Levophed or norepinephrine, and our second line is vasopressin, and we're just going to go down this line. I want to be thinking, well, what does their cardiac output look like? Maybe they need some inotropic support. Are we considering everything? And knowing how these medications work allows you to be just more of a participant in those conversations, which for me is the fun part. So I hope this was helpful. I'm going to drop a little, that took a little bit of time, so I don't have time to go through practice questions here at the end, but hopefully that was interactive enough for everyone. Let me send a link to our next, oops, there we go, to our next webinar there. And then, yeah, on the site, check out Archer Review for CCRN if you haven't already. So glad it was helpful. Thank you, everyone. And we will see you on November 18th, so even just a little bit longer. And we'll do probably back to normal practice questions. Can you let me know about the CCRN program? Absolutely. Yeah, no, I totally get you. So the CCRN program, we just launched it in February, and we've had quite a few students try it out now and seem to be being successful on their exam, which is super exciting. We have a question bank of over 1,000 questions. And the percentages in those in the QBank match the test plan, which is why we're going to be doing some revisions to make sure we've got the right amount of questions in the right system to make the QBank really reflect what the exam will look like. But we want to make sure we do that when we see that new test plan launching. And then it'll be over 13 hours of on-demand video content, all taught by me. So if you like this teaching style, then you would probably like those on-demand videos. If you don't, then maybe you wouldn't. I know it's hard to listen to over 13 hours of someone's voice and teaching style, so totally understand that. Is it good for just understanding overall ICU, not just exam focus? I really think it is. And if somebody else, I know we just got a comment here, signed up, love it so far. So grateful. That's awesome. Thank you. I think it is. You can get CE contact hours for it. I definitely tried to keep everything as concise and to the point of like high yield information as I could, but I'm a really big believer in not memorizing really anything. There's some things you have to memorize, but my goal is that you understand, like what we talked about today. I want you to understand why we choose one medication over another. Understand why there's a certain set of symptoms with a disease process. Instead of memorizing that set of symptoms, if we understand normal anatomy and physiology and we can understand what went wrong in the pathophysiology of a disease process, then you'll never have to memorize anything. And that's really my goal with that course. So I do hope that people leave the course and feel like they can be successful on their exam, but also walk into the ICU a little bit more confident the next day. So yeah, I think it's good for just overall knowledge. Um, yeah, and we do have a year long access option as well. So if you're not in exam focus and you just want to have access to the content for a little bit longer, that might be a better choice. Make a session on ventilators. Absolutely. I can totally do that next time. Um, I do have, I think it was an hour long webinar. If you search on YouTube, Archer Review mechanical ventilation, I did a webinar, I think back in February or March, all on ventilators. So definitely take a look at that. It's just live on YouTube. So, um, yeah, Archer Review, CCRN, mechanical ventilation, you should be able to find it. Okay. Oh, good. Some gems on YouTube. Yeah, that's so good. I'm so glad. Yeah, we've got a lot of these webinars that we put up there. So thank you guys so much for being here. Thank you for watching, and we will see you next time. Good luck to anyone taking their test before we come back. Y'all are gonna do awesome.